Hello, everybody. Uh, of course, it's a very difficult to have a presentation after a so exciting presentation. My speakers, first speakers, but first of all, I'd like to introduce myself and my clinic. Now it's maybe the Ukraine know everyone. Yes. Okay. It's everyone know about the Ukraine because in my country, it's going on the war, and so we are working 24/7. Uh, Too much work, but nevertheless, we are having the procedure, the whole kind of procedure, and I'd like to introduce first of all my clinic. I'm the chief of the clinic, municipal clinic, and the head of department of the university. Professor Serdiuk Valerii, my name. Dnipropetrovsk Regional Clinical Hospital is the only hospital in which provides ophthalmological care in the region of the 5 million people in Ukraine, and provide highly specialized ophthalmology assistance to servicemen and jury in the war zone and the temporary displaced person, and making all kind of procedure, as I say. This is the slides about our clinic, how we're working. Very fast. Okay. That's a small introduction. So, okay, my first speaker is talking about the more advanced about the intensity lens, and that um, I would like. Oh my God, I'm sorry. I'm sorry. I would like to begin explaining how intensity to attract the attention of many surgeons around the world and came into their hands. Hanita's goal was to create a better trifocal intraocular lens that would be provide a smoother focus curve from infinity to 40 centimeters without the significant dips, approaching natural vision and reducing nighttime disturbances. To achieve this, the idea was to add two new focal points to create flatter the focus curve. But how does it lens reduce disturbances? To understand this, we need to look at the difference and disturbances between the continuous and discrete energy distribution. To create this intensifier without reducing the energy from existing focal points, Hanita had to develop more efficient lenses than lost less light than existing focal lenses. We know that the distributions of energy in the existing lens consists to 20-40%, and in the intensity lens we can get it, and the energy distribution in intensity lens consists 6.5% only. To this end, they devised a patent dynamic light utilization design method. Unlike the traditional addition of multifocal profile, they use the iterative approach, where each iteration the shape of the lens is slightly modified until the desired focus distribution is achieved. This method ensures the precise and uniform energy distribution and makes the lens highly efficient. In the slide, you see a familiar combined design where each step delivers energy and specific distance. The new patented dynamic light utilization design allocated energy at an all distance, each inward-facing surface, provide far and intermediate focus, and each outward-facing surface provide near and intermediate focus. Because the lens is smooth, the transition between distance occurs gradually. Now you see the spectrograms, what we can do modify the scattering function. On the top, you see the intensity lens, and further confirms the smooth distribution of light across various focal distances compared with the other bitrifocal and the quadrifocal spectrograms. Technical characteristics of the lens include the following advantages, like a flat focus curve, low level of disturbances, continuous interrupted vision, no need to search the focus, and light contrast even under mesopic condition. We performed surgery of 15 patients with a bilateral implantation of artificial intraocular lenses for cataract and refractive lens exchange. Satisfaction was assessed using the modified VF40 questionnaire. This photopsia was assessed using the visual phenomena questionnaire. Assessment was performed with the Pearson correlation for usual acuity, levels of satisfaction and dissatisfaction. The reliability of the correlation was evaluated using regression analysis. Fifteen operated patients, 30 eyes from 1st January 2025 to 25 July 2025. Mean age 62, plus minus 10 years. Woman 9, man 6. All surgery were performed by one surgeon using the standard technique. Only somatically healthy patients without renal pathology were included. This slide shows the monocular and binocular defocus curve of intensity lens in various ethnic groups from a Hood study, Dr. Hood study, show the blue and the orange respectively. And the green line show our defocus curve, which correlated with Dr. Hood data. Now the closed defocus intensity lens is 2, that the monofocal lenses look like the monofocal lens, very flat area. This slide presents study of doctors Bellucci, Ruta, and Cataract comparing the intensity lens with the other diffractive lens. We see that the focus curve of intensity lens has significant advantages in the intermediate distance relative to other diffractive lenses. In the fourth image, down right, bottom we see the comparison of intensity defocus with a DOF lens. After the focus curve are closed, the intensity lens offer the clear advantages and near distance. How we evaluated the data, our data. The patient satisfaction was assessed using the VF40 questionnaire with the extra question. Answer we ranked from all to 4. All was major difficulty, 4 no problem. Questions not applicable to the patients were skipped. The number of answer questions was counted and average value calculated and then multiplied 25. Dissatisfaction was assessed similarly because there were only 4 ranks, all 3, and multiplied at 33.33. The third block assessed spectacle use for distance, computer and reading from all to 2, all never to almost always. The fourth block gave the overall conclusion, all dissatisfied, 3 very satisfied. The fifth block was confirmatory. Patients were asked whether they would repeat the procedure as part of treatment. This question was used to exclude response who answered questionnaire at random. Our patients reported insufficient satisfaction when driving at night and when reading the small print. The instruction of medication, the ingredient list, according 75 and 85% respectively. The highest satisfaction was noted when reading the books, and I'd like to know the electronic books and the print books. Recognizing people nearby and recognizing obstacles such as steps, ladder, and curbs. The average level of patient satisfaction was near 95%. The highest level of dissatisfaction were reported at halo and glare, particularly the professional drivers, 31 and 33% respectively. The patients were completely satisfied with color perception. The overall level of dissatisfaction was 13.5% actually. Detail as shows that 70% keep the absent of vision problem. Only 21% there was the mild dysphotopsia, and just only 9% moderate dysphotopsia. All percent severe dysphotopsia. None of respondents reported about severe symptoms. For the two worst categories, we found halo 26% absence, 46% mild, and 26% moderate. Glare, accordingly, 33% absence, 40% mild, and 26% moderate. What about the spectacle use? The glasses were sometimes used just only 20% of patients and for reading. The most patients pointed out difficult reading small print instruction on the medication, for example. And they when they read in the gray text on the gray paper. Also, they didn't use glasses when reading from the phone. For intermediate vision, computers and tables, patients didn't use glasses. This slide presents our survey data, which fully correlate with the published global data. Here it is the list of relevant articles of intensity lens. So the overall satisfaction rate was near the 95%. The lowest satisfaction was night driving, just only 75%. The level of dissatisfaction was 13.5%, with halo and glare contributing most of dissatisfaction. To confirm patient satisfaction, the final question asked whether the patient would agree to undergo this treatment again, and 100% respondents answered positively. Thank you very much for your attention. I hope we will win, and I'd like to thanks to you to share our time. Very exciting. Thank you.